international threat. And also, member states are required to develop the core capacity to prevent, detect, respond to the event. And also shifted from the old IHL to this revised IGL, from controlling the borders to containment at the source, and from disease list to all acute public health events, and from preset measures to adapted real-time flexible response. And based on the SARS experience, UPRO, Western Pacific region, developed APSET to ensure member states developed core capacity to prepare for the next pandemic. It tries to help member states in implementing this revised international health regulation, IHL. We had many lessons identified after the SARS, since we were not well prepared and experienced so many unexpected issues. We noted that when pandemic occur, we should expect unexpected. I would like to share two things we noted as important in preparing for the next pandemic after the outbreak. The first is that in English, we often use the word lesson learned, which actually gives us a feeling that you have already fixed it. But when we listed the challenge we face in SARS, we actually noted that less than 20% of those lists identified can resolve quickly, but the remaining items take times, since we have to modify or even we have to develop a new system. And then we decided to call that lesson learned when it is fixed. And until that time, we decided to call lessons identified. The second is that often we say the problem, but the problem we think of is just a phenomenon. And we have to analyze what is really causing it with the output and objectives in mind and find a solution that fits to the context. To do that, I promoted asking why? And I noted the capable people also asking themselves 5 times whys. And after that, zoom out and identify the solution that fits to the context. Actually, to distinguish what and how was also the point we learned through the implementation of APSET. Developing a system takes time. And we revised the action framework 3 times and implemented those 3 framework more than 50 years till COVID-19 occurred. Implementing APSET created several important approaches, and this is a part of how to prepare for the next pandemic. A system approach needs a long-term plan and a step-by-step approach. The system also needs to fit to the context. Therefore, we need to understand each country's culture, economy, and political willingness, and needs to learn and improve after responding to any outbreaks. We also distinguish a response plan and a response capacity so that we can effectively develop a system. We name it as a 2-tier approach. Those systems requires nationwide system. And to make that happen, we need a very strong government leadership. When we developed APSET, as I mentioned, our region is so diverse. So first, we consult with the countries and respect each country's priority, and actually grouping them if they have common elements. For example, the second version of APSET had 8 focus areas: surveillance, risk assessment and response, laboratory, zoonosis, infection prevention control, risk communication, public health emergency preparedness, regional preparedness, alert and response, and monitoring and evaluation. Upset also carried innovative system while we were implementing Upset because we found there's some need, such as a event-based surveillance, multi-source surveillance, surge contact tracing system, FET. Event-based surveillance is a good example. Before SARS occurred, the surveillance system existed, need a definition. And the new diseases, which is not able to capture the new diseases with the definition, was obviously not effective surveillance. And that's the reason why we created this event-based surveillance system in our region. And now this event-based surveillance system is used by many countries around the world. We also developed a practice to offer a guidance for pandemic based on the experience of upset implementation. And we learned from that there is a very obvious but important things. This is the guide we developed for the 2009 pandemic of H1N1. And you can see very obvious things. That is, it is very clear infectious disease control is a series of decision-making based on the information gathered. Decision-making for health services, decision-making of public health intervention, and we have to communicate them. During COVID-19, I'm sure you made a decision, and some of you may contribute to the leaders and people making decision. The upset implementation made a good progress. The independent group published a paper in 2010 that comparing the 6 regions and reported that the Western Pacific region had made a progress and shortened the time needed to detect the outbreak. And we continue to implement upset to prepare for the next pandemic. Then COVID-19 occurred. Our event-based surveillance detected a known pneumonia cluster in Wuhan, China on 31st December 2019. We switched on our response on January 2020. We used the system we developed through upset implementation for more than 15 years to respond to COVID-19. We first focused on China, while we also encouraged countries in the region to switch on to detect early and prepare contact tracing and quarantine, isolations quarantine. We supported countries in improving their response, public health, and the health system. And we found a system we developed effectively contained and suppressed the spread. But not only one country, but all countries in the region need to switch on response. Given that pandemic means virus will spread to all countries and all communities at the end. The government connected to the local government and the local government to the community, and we connected to the country to share information and develop the guidance for the response. Country improves their response, modify their response based on the response experience in the front line. But if they are connected to other countries, they can also improve based on the information and response experienced by the other countries. Actually, upset implementation connected member states before COVID-19, and we use that connectedness in response. And again, we noted very obvious things. If we have a system and practice before the pandemic, we could convert them and use them for the pandemic response. We connected member states and facilitated the sharing of information. Information shared and came up with the series of guidance. The 3C, or Japanese call it Sanmitsu, and prospective contact tracing developed by Japan was one of the good examples. We analyzed the data and shared this to member states. And many countries hypothesized that the cluster would occur in similar setting and set up similar approach. The information that we frequently shared and discussed was a public health intervention, or NPI. At the very beginning, initial stage of COVID-19, since we didn't have sufficient information, we used experience of seasonal influenza control and the 2009 influenza pandemic response. But with more information, its effectiveness and feasibility we gained, the NPI were modified. The base of that decision-making goal was to save people's lives while minimizing the economic impact. We had a common understanding that once the number of cases exceed the healthcare capacity, the risk of death increases. The word exceed made people's mindset a horizontal line. The horizontal line ends up with the y-axis, number of beds, leading to action, increase the number of beds. And China, Korea, Philippines share their excellent experience in doing that. However, we observed that increasing the number of beds has a limitation and was not that easy. And we noted that if the number of cases has been growing and expected to reach that red point, we must strengthen public health intervention, switch on NPI. Then we should have vertical line to discuss about the timing of switch on, and later, of course, switch off, and the level of the NPI. We developed and share the guidance based on what we observed, analyzed, and discussed with the member states. In that guidance, we also learned, and we shifted our approach from starting with the data collection, data analysis, and consider NPI, to start with already thinking the next options of NPI. And based on that, we collect the data to make such decisions and decide. As I mentioned, infectious diseases is a series of decision-making at the right timing, in the timing needed. We found that this starting with the potential options of decision-making that you're going to make and collect the data was much more effective in NPI decision-making. We call this approach as a hypothetical approach with a multi-source surveillance system. Now, although I mentioned that I focus on how, but now I would like to touch on three what I think it's very important to address it to prepare for the next pandemic. I mentioned that the Lancet referred to suppression approach based on the upset. Our region promoted the approach utilizing different levels of NPI to suppress the outbreak and fit it to their context. In the beginning, as I mentioned, when we didn't have sufficient information and anticipated, the virus rapidly spread and potentially cause a big number of cases, end up with dying. Many member states took the actions of a non-zero risk approach. This zero risk approach, we noted an important issue behind this. The zero risk approach is to contain the virus if possible, and if not, feasible actions to buy time to be ready for responsible response nationwide. The action requires every individual to follow the decisions of the leaders and take the same action. In other words, leaders need to make a decision on behalf of the people, and expert need to analyze information and provide options to the leaders. And the decision needs a good communication. Once that stage is over with more information and capacity to respond, including a vaccine coverage nationwide, then shift to non-zero risk approach. This stage is no longer only leaders, but also other group and individuals need to make their own decision based on the risk information shared. So we need a good risk information to be shared. This effective decision making, decision making and the communication is the first what we need to address to prepare for the next pandemic. The second is that, as I mentioned, that the upset approach is step by step. This is the slide shown a step by step related to surveillance for the past 15 years. We started with training the rapid response team in the front line and strengthened existing indicator-based surveillance and created a new event-based surveillance and FET as a central team for investigation and introduced the risk assessment practice and introduced multi-source surveillance. We use all this surveillance capacity in responding to COVID-19. Yet we face two challenges. One of that is that we need some information about the spread of virus by paying attention to asymptomatic cases. And the second is getting effective about getting information effectively about genetic information about the virus and its transmissibility and virulence. Interestingly, while responding, many countries and ourselves started the discussions how to address these two issues. And then they came up with this two system and now started implementing it. Lastly, we had a big challenge. We had many studies of drugs and vaccines worldwide. But unfortunately, our region faced a clinical study and trials challenge. I was actually very impressed by the United States. They converted the existing clinical trials network for HIV, connecting several countries around the world, to response to COVID-19 and created the data for COVID-19, including vaccines. And I'm afraid our region was not well prepared. And this is another what we need to prepare for the next pandemic. To that, I believe ARISE has enormous potential to prepare for the next pandemic. This is my final slide showing and sharing how to prepare for the next pandemic based on the upset experience. First, we need to list up the lessons identified and analyze that lessons identified with the objectives in our mind. Second, find a solution that fits to the context. And third, develop action plan and establish a system. And if we're addressing the system, we need to have a long-term plan and step-by-step approach. And we have to try it as a prototype system. We can try that during the peacetime for other issue as prototype and test it and improve it based on that experience. And finally, we can switch on when a pandemic occurs. A pandemic means a pathogens, virus, spread beyond the national border. And ARISE connects the people committed to clinical study and trial and develop the regional network that will become, I strongly believe, critical system for the next pandemic. Thank you very much for listening. Thank you very much, Professor Shimokawa.
Well, thank you very much, Dr. Kasai, for your excellent special speech based on your own experience with WHO. Thank you very much. Okay, so next, I'd like to ask Dr. Kato to give us a keynote speech. Dr. Kato is a professor of Department of Infectious Diseases at RUHW. So Dr. Kato, please.
I appreciate Professor Shimokawa, the chairpersons, and other project members for inviting me to this symposium again. It's already been 5 years since COVID-19 first emerged in Wuhan, China. Almost all my activities were dominated by COVID-19 related cases during the 3 years following our hospital's opening in 2020. Personally, I feel that the challenges we faced during this time, starting from the response to the Diamond Princess cruise ship incident, were some of the most difficult in my career. Now, as life gradually returns to normal, it seems COVID-19 is quickly fading from people's memories. I'm sincerely grateful for the opportunity to reflect on this pandemic today. The World Health Organization reported COVID-19 ranked as the second leading cause of death globally in 2021. However, from the start, it was noted that there were significant differences in mortality rates between countries. This map summarizes excess mortality due to COVID-19 over the first 2 years of the pandemic. Because of the high number of cases and the limited test capacity, estimating mortality rates is challenging. However, this data published in The Lancet reflects comprehensive analysis by an international team, and I believe it is highly reliable. As shown, countries or regions with higher mortality rates are marked in orange, including Russia, the United States, countries in Latin America, South Asia, and Southern Africa. In contrast, lower mortality rates were observed in the Western Pacific region, which includes Japan, China, and Australia. Even in these countries, many deaths, particularly among the elderly, were reported after the Omicron variant emerged. However, during the first 2 years of the pandemic, these countries managed to control the number of deaths. It's believed non-pharmaceutical interventions such as wearing masks and physical distancing played a significant role in reducing transmission and death. As I mentioned during last year's symposium, the Asian region where we live has faced significant challenges in the past, including the emergence of H5N1 avian flu in 1997 and SARS in 2003. In Southeast Asian countries like Vietnam and Indonesia, experiencing recurring H5N1 outbreaks, which heightened awareness of severe acute respiratory infections among healthcare workers and the general population. This heightened vigilance likely influenced early pandemic responses in the region. When discussing ways to improve patient outcomes during the pandemic, especially in reducing mortality, there are many angles to consider. These include coordinating healthcare institutions through local and national governments. Today, I'd like to focus on the development of rapid or living treatment guidelines for healthcare providers from my experience. As I shared at last year's symposium, one remarkable aspect of this pandemic was a proactive approach to conducting clinical trials from the early stages, which accelerated the search for effective medications. One particularly noteworthy example is a recovery trial led by Oxford University, which was carefully prepared following lessons learned from the 2009 influenza pandemic. In June 2020, the recovery trial demonstrated the effectiveness of an inexpensive and widely available drug, dexamethasone, in treating severe cases of COVID-19. This finding represented a significant turning point in COVID-19 treatment. While countries like the US, UK, and China led the way in developing new drugs, unfortunately, Japan's contribution in this area were relatively limited, This issue has been recognized in government reviews and remains a challenge for the future. Hopefully, the ARISE project will contribute to this area in the next pandemic. Let me turn to the topic of rapid treatment guidelines for healthcare providers. Through research funding from the Ministry of Health, Labor and Welfare, I had the opportunity to be deeply involved in developing these national guidelines. While the development of new drugs is undoubtedly critical, I firmly believe that clearly communicating current standard treatments, including supportive care, to healthcare providers is equally important. This slide illustrates a number of notifications issued by the Ministry of Health, Labor and Welfare to medical institutions in the first half of 2020. As you can see, the number of notifications increased proportionally with a rise in domestic human cases. This flood of information created what we call an infodemic. Notifications as administrative documents are often not written in a way that is easy for busy healthcare workers to understand. Based on my experience assisting with quarantine operations on the Diamond Princess cruise ship in February 2020, it was clear to me that Japan would soon face a large number of domestic cases. Recognizing this, I led a research team to create rapid treatment guidelines, which with the ministry's approval were disseminated to healthcare facilities nationwide in March. Now let's move on to the concept and the structure of the interim guidelines we developed. As I mentioned earlier, our primary goal was to compile various pieces of information into one place, specifically tailored for healthcare professionals. This was an urgent need, as navigating through scattered and dense information can be overwhelming during a crisis. To ensure clarity, we prioritizing creating diagrams and tables whenever possible, aiming to make the guidelines easy to follow. Our goal was to present the most up-to-date standard treatments with the overarching aim of reducing mortality. The structure was fairly straightforward. It included key sections such as the pathogen, epidemiology, clinical features, case definitions, diagnostic methods, reporting protocols, severity classification, management strategies, pharmacological treatments, infection control measures, and discharge criteria. This comprehensive approach ensured the guidelines addresses the full spectrum of clinical care. Of course, in such a rapidly evolving situation, staying current was crucial. That's why the guidelines underwent frequent revisions to incorporate new critical findings and the information as they became available. Over a span of 4 years, we carried out 9 major updates and 12 minor updates. If you look at the timeline here, you'll notice the first 2 years required the most frequent revisions. This was expected given the rapid pace at which new evidence and global recommendations were emerging during that time. Let me now explain how the revisions were made. We carefully selected updates based on various sources, including notifications from the Ministry of Health, Labor and Welfare, updates from WHO guidelines, opinions from domestic academic societies, and of course the latest major academic papers. So how were these guidelines received by health? To find out, we conducted an online survey in March 2023, targeting 500 physicians from designated medical institutions across the country. About 300 responded, and the results were quite encouraging. The overall satisfaction score was 8 out of 10, which we believe is a positive indication of their usefulness. Around 70% of respondents had downloaded the guidelines from the Ministry of Health's website, and many accessed them on smartphones or tablet, highlighting the importance of providing electronic versions. Interestingly, the sections on pharmacological treatment and severity classification were the most frequent referenced. On the other hand, only 20% of respondents referred to the WHO guidelines in English, underscoring the continued importance of translating international information into Japanese for local use. Building on the survey findings, let's delve deeper into the most frequent reference section of our guidelines, pharmacological treatments. Japan was fortunate to have relatively early access to drugs developed overseas. For example, in 2020, the antiviral drug remdesivir was granted emergency approval, though initially for a limited patient population. Dexamethasone, based on the recovery trial results, was introduced in our guidelines by July 2020 and rapidly adopted across the country. Neutralizing antibody therapies, which became available after 2021, were effective initially, but saw reduced utility following the emergence of the Omicron variant, which significantly weakened their effectiveness by 2022. Newer treatments such as nirmatrelvir, ritonavir, and ensitrelvir were approved, completing the current lineup of therapeutic options for COVID-19. However, the availability of these treatments and their effective utilization often don't align perfectly. This is where the role of well-structured treatment guidelines becomes evident. They bridge the gap between drug development and practical implementation, ensuring therapies are used appropriately to save lives. A key question arises here. Do these treatment guidelines directly contribute to improved patient outcomes? This question has attracted much attention and discussion. Last year, a research team in the UK published a study analyzing the alignment between national treatment guidelines and the WHO's recommendations. The graph here illustrates a frequency of guideline updates in different countries. Countries with the most frequent updates, including Japan, are shown in green, which Japan's guidelines, which our team developed, were recognized for their high frequency of revisions, an important factor in maintaining relevance in a rapidly changing pandemic. Interestingly, regions with less frequent updates, such as parts of Latin America, South Asia, Southeast Asia, and Africa, often coincided with areas experiencing higher mortality rates. However, exceptions like the United States suggest that frequent updates alone don't guarantee better outcomes. Other factors such as how well the guidelines are implemented and the quality of supportive care likely play significant roles. Next, let's consider how well Japan's guidelines incorporated WHO recommended treatments. This chart focuses on the degree of alignment between WHO recommendations and the national treatment guidelines. For therapies aimed at mild cases, countries with higher concordance are marked in blue, while those with lower agreement appear in green. Japan, along with the most Asian countries, demonstrated a high degree of alignment. Meanwhile, countries like the United States and several in Latin America also showed strong alignment, despite facing higher mortality rates. This discrepancy highlights the complexity of the relationship between guidelines and patient outcomes. It suggests that while comprehensive guidelines are essential, their impact depends heavily on effective implementation and other supportive measures. To conclude, let's revisit the key points of today's presentation. First, Japan and the Western Pacific region had lower COVID-19 mortality rates during the pandemic's initial 2 years. This can likely be attributed to effective non-pharmaceutical measures such as mask wearing and physical distancing. Second, drug development and ensuring access to effective treatments remain critical for reducing mortality. Initiatives like the ARISE project hold great promise for the future. Lastly, healthcare professionals on the front lines are essentially vulnerable during a pandemic. They often face the same information shortages as the general public. In this context, government-supervised treatment guidelines serve as a crucial resource. While our small research team led this effort, I believe that the national organizations should take similar initiative in the future pandemic. Thank you for your attention.
Well, thank you very much, Dr. Kato, for your excellent keynote speech. Next, I'd like to ask Dr. Tetsuya Matsumoto to give us another keynote speech. So, Dr. Matsumoto, please.
I'm Professor Matsumoto of the Department of Infectious Diseases, and thank you so much for giving me a chance for today's talk up in AMED IUHW Symposium as a keynote speech. So, title of my talk is Preparing for the Future of Pandemics and Japan's Integrated Approach. This slide shows the global impact statistics of COVID-19. Of course, you know about 750 million patients are infected, and also total death number is 7 million, and affected countries are over 200. So you see, you can understand there are many global impact of the COVID-19. So this slide shows the cumulative COVID-19 deaths per million in each countries. You can see here in Japan, and also United Kingdom is here, and the United States are here. So we can see so much difference in these countries. This slide shows the comparison of daily COVID-19 deaths per 1 million people. After the starting the pandemic in 2020, we can see so many people are killed in the United Kingdom and the United States. But in Japan, we can see that compared to these countries, we can see the low number of people are killed. So why Japan maintained a low number of deaths? So I think infection control measures such as universal masking prevented rapid spread of infections, and also vaccines and therapeutic drugs were available during the periods of increased infections. And in Japan, many people, including the elderly, activated. So this slide shows the 3 C's. This is the popular word in every countries. One is closed spaces and crowded places and close contact settings. Many people in Japan avoided these kind of 3 C's. And for the diagnosis, this slide shows the gene detection methods of COVID-19 approved in our country. At first time, we couldn't do the PCR test enough. But after that, in our country, many companies developed these kind of gene detection methods for the COVID-19. And also, this slide shows the antigen detection methods of COVID-19 approved in our country. Yes, so many immunochromatographic tests are developed, and we can buy this kind of kit at the pharmacy. That means we can do the test by ourselves. And this slide shows the COVID-19 drugs approved in Japan. Yes, after development of the remdesivir, these kind of antibodies and other type of drugs are developed. And also for the outpatient clinics, so molnupiravir, nirmatrelvir, ritonavir, and also estradiol, these kind of drugs are used for the outpatient of the COVID-19. And Zocoba, estradiol, is developed in Shionogi Pharmaceutical Company. So this slide shows the COVID-19 vaccination coverage by age groups. So we can easily understand higher percentages, especially in the elderly people. So we understand the importance of the vaccines for the prevention of the COVID-19. One of the meaning is herd immunity, and also protecting the high-risk groups, and also protect of the healthcare workers. So I'd like to talk about the strategies of new vaccine development for next pandemic. So talking about the development of the vaccines of the COVID-19, we can see that this kind of history after starting the pandemic of the COVID-19. Yes, Moderna and Pfizer developed messenger RNA, and it is used, it has been used worldwide in each countries. So in our country, Meiji and Shionogi and Daiichi Sankyo also developed a vaccine and COVID-19, and it was already approved in our countries. So I have to talk about AMED. Yes, this is the Japan Agency for Medical Research and Development, and this is the president of the AMED, President Mishima. So AMED is established in 2015 in April, and at that time Japan's medical R&D faced fragmented funding and inefficient clinical trials, slowing innovations. So AMED was created as a control tower to coordinate research from basic to practical applications. So there are two major functions needed for AMED. One is implementation of medical research and development. It may be the basic research support, I think, and also improvement of the infrastructure for clinical research. Of course, development of the vaccines and the new drugs, it needs clinical trials. So improvement of and the strengthening of clinical trials core hospitals is important. I was working as a program supervisor of the therapeutic drug development programs for COVID-19. And this slide shows that in the fiscal year of 2019, these kind of 5 projects are supported by AMID. But talking about AMID, supporting of the infectious disease is not the only field. Yes, cancer and other type of fields of research are supported by AMID. And after the pandemic of the COVID-19, SCADA was established. SCADA was established in 2022 as a part of Japan's vaccine development strategies. It provides comprehensive management of vaccine R&D, both before and during infectious disease emergencies. So, I also working as a program officer of the SCADA. So, talking about the SCADA, there are many projects supported, and there are many categories. So, I'd like to introduce about one of the categories of the vaccine development. The goal of this category is accomplishment of phase 2, and also 5 billion yen per research project are supported. And also development period is up to 5 years. You can see these kind of projects are supported by AMID and SCADA project. Cervical virus, SARS virus, Nipah, dengue, smallpox, influenza. These kind of infections are supported for the development of the vaccines. And another categories is new modalities contributing to vaccine development. So the goal is accomplishment of phase 1 and 1 billion yen per research project and up to 5 years. So I'm sorry for the busy slide, but there are many kind of projects are supported, such as Ebola and multifunctional vaccines, like that. So next categories are development 2. So the goal is non-clinical POC and 100 million per yen up to 2 years. So you see there are many kinds of projects are supported by SCADA, and yes, some of them has reached show the good results of these kind of research. Talking about preparing for the pandemic, it is important to divide the stages. One is normal time, and another is time of emergencies. So at the normal time, we have to prepare for the basic research and also for preparing for the clinical trials. And then, at the time of the emergencies, it is important to use these kind of vaccines developed during the normal times and their early commercializations. And also, it is important to do the mission in a shorter period, such as 100 days mission. And also, it is important to collaborate to each country and each associations in worldwide. So this slide shows one of the collaboration of the aid in these kind of associations and countries. So this slide shows the such as Australia, Spain, Lithuania, UK, Singapore, United States, such like that. So collaboration and cooperation with external institutions is also important. So for the summary, our experience with COVID-19 has demonstrated that no nation can address global health challenges in isolation. Success in preparing for future pandemics depends on our ability to work together, share knowledge, and support one another. The continued collaboration and commitment to scientific excellence, we can build a more resilient global health system capable of responding effectively to future challenges. So I'd like to finish my talk. Thank you so much.
Well, thank you very much, Dr. Matsumoto, for your excellent keynote speech. Okay, and now let's move on to the next program, presentation from each country. In this section, we have 7 speakers from 7 Asian university hospitals. And this section is chaired by our 2 professors at Department of Infectious Diseases, Professor Junko Tanuma, and Professor Naoko Yamamoto. So please.
Good afternoon, everyone. My name is Junko Tanuma. Thank you for Shimokawa Sensei for your kind introductions. And as Shimokawa Sensei shared with us, I and Senior Professor Naoko Yamamoto will be introducing the speaker in turns. And after all the 7 presentations, we will have 25 minutes for discussions. So before going to the first speaker, maybe I have to share some very important housekeeping stuff. So each presenter has only 10 minutes, and please, as the time is limited, so please adhere to the time limits and be punctual. So if you exceed the 10 minutes, maybe we may have to ask you to conclude your presentation in the middle. We're so sorry for that. So yeah, so let's start. Please let me invite the first speaker, Dr. Lee Min Zhang from Hanoi Medical University. Dr. Zhang, please.
Thank you, Madam Chair, and thank you, the organizer, for inviting me to speak at this important symposium. This is my pleasure to participate in. This is the second symposium that I participate in the ARISE program. So my talk today focusing on the strengthening healthcare workforce in order to prepare for the new infectious disease pandemics that many have expected would arise in sometime in the future. I think the keynote speaker have emphasized various aspects of the preparing the lesson learned, lesson identified, and how we prepare better for the next pandemics. And I think one of the issues that all of the speakers really highlight is that we need to prepare the workforce. And this is not only for developed countries, high-income countries like Japan, but also and especially critical for low and middle income countries like Vietnam and many countries that are represented in the ARISE consortium. So my talk will focus on this particular aspect. This is on the left-hand side is the diagram that published by a few authors from Vietnam and the US. and they draw on the various studies and lessons learned from the response to the COVID pandemic and highlight some of the effects of the pandemic on healthcare workers. And looking at this diagram, we can see that the effects would be shown or be happening at the individual levels, such as the burnout, such as the stress, such as the lack of motivation, or even fear and isolation, and also the leading to reduced quality of life. The effects could be also seen at the working environment or in the conditions in which the healthcare workers are functioning. For example, the increased workload, that's for sure, shortage of the PPE supplies, and poor coordination, not only among healthcare workers, but also between healthcare workers and many workforce that from other sectors. Because responding to pandemic like COVID-19, it's not only healthcare workforce, but also from other sectors as well. And of course, is the decreased income, and that's really affect not only the healthcare workers, but also their families. So in short, we could see that there's a multiple level of risk factors, but also the effects on the healthcare workers as they are confronted with the new pandemic. And in Vietnam, another aspect that we observed during the pandemic, and I think that this is not just for Vietnam, but also for other low middle income countries, was the shortage of healthcare workers in order to respond effectively to the pandemic. For example, during the peak of the COVID-19 during the in the southern part of Vietnam, in the middle of 2021, during the Delta wave, the Minister of Health had to mobilize almost 100 delegation of healthcare workers from other provinces, totaling more than 16,000 personnel to move to the Ho Chi Minh City and adjacent provinces in order to support the healthcare workforce during that peak of the pandemic. So despite the suppression strategy that we adopted early on, following the guideline from WHO, we still faced with the significant shortage of healthcare workers, and the government had to mobilize the healthcare workers from other sources, other provinces, and the challenge is that the quantity of healthcare workers is needed is sort of vary during different phases of the pandemic. And this is our study in one of the provinces in the middle of Vietnam, the Nghệ province. As you can see in the table, during the Delta peak, right, in this September, as we survey in September 21, there was the shortage of healthcare workers in several critical areas, especially nurses. For example, the rep are the one that are in shortage, and we use the WHO workforce estimator to estimate the number of workers that were needed during as based on the number of cases. So we see that there's a critical shortage in terms of nurses, in terms of the laboratory technician, in terms of the physician specialized in respiratory diseases, and also the social workers and psychological counselors who could support the healthcare workers as well as the patient. But during the Omicron variant, as you know, that the number of cases was less, and also we were able to manage better the pandemic. We didn't see a lot of shortages as during the Delta peak during the peak of the Delta variant. What it means is that how do we make the planning? How can we prepare for the healthcare workforce so that we can respond effectively to the pandemic at different stages, which require different numbers of healthcare workers. And I think this is the challenge that is still yet to be resolved for Vietnam and many other countries. We also this is the same study. We are looking at the several risks in terms of the infection in one in the north and one in the central was almost about 1 per 1,000 person day at risk, and this is the risk similar to during the peak of the Delta, and remind you that this is during the Omicron period. Insufficient training. Yes, the COVID-19 diagnosis and treatment was insufficiently provided, training provided for healthcare workers, especially in the provincial level and district level, where they had to take care of the healthcare of the critically ill patient. And I think that one of the keynote speaker mentioned about how we update the guideline, the treatment guideline, and using different modalities to update the guideline. This is critically important for countries like in Vietnam. And last but not least is the mental health impact. I think even after the COVID, after the pandemic sort of subsided, and we still saw a lot of the challenges in terms of the mental health, especially the PTSD. And this is the survey. We show that the more than 20% of the almost 20% of the healthcare workers at different level, province, district, and commune, experience some sort of PTSD or at risk of PTSD even after a couple of months or years after the pandemic. So let me conclude my presentation by mentioning one of the very important aspects of preparing for the pandemic, which is the field epidemiological training. I think Dr. Kasai mentioned the critical need to implement the event-based surveillance, but also the response, detect response, and so on for the pandemic, for the next pandemic. And it is in order to do that, we need to have a sufficient number of field epidemiologists. And this is not happening in many countries, including especially the low and middle income countries like in Vietnam. We haven't met the required number of the field epidemiologists per 500,000 population. Right now is very, very low. We haven't reached the required. And especially the current workforce in the surveillance is very poorly trained, poorly equipped in order to detect and prepare for the next pandemic. So look, I think what I propose is that for ARISE, in addition to preparing for the clinical trial in the next phase, we may want to focus also on regional training and regional collaboration and network of the FETP personnel. And this is something that would help us to well prepare for the next pandemic. So in conclusion, I want to again emphasize that the healthcare workers are especially those at the front line, at the critical, often critically faced with many effects of the pandemic, and we need to prepare them for that. And really, the arrival of the COVID-19 epidemic actually aggravated many issues already faced by healthcare workforce in low and middle country settings. So in order to prepare for the next pandemic, in addition to the clinical trials, we also have to prepare the healthcare workforce especially in critical areas such as field epidemiology, intensive and critical care, primary care, and disaster preparedness. And I wholly promote the regional collaboration in field epidemiology training in order to prepare us better for the next pandemic. Thank you for your attention.
Thank you for Dr. Zhang for your concise presentation and suggestions. So I would hand over to Yamamoto Sensei.
Yeah, thank you very much. So our next speaker is Dr. Neom T. Kam Hom from University of Medicine and Pharmacy at Ho Chi Minh City. So Dr. Neom, floor is yours.
Good morning, chairman and panels and attendees for the Sympoium for the Arise program. I'm Dr. Nguyễn Thị Cẩm Hường. I come from the Department of Infectious Disease of University of Medicine and Pharmacy of Ho Chi Minh City at Việt Nam. And from the COVID-19, we have lessons from the 5 lessons from facility that's the take part in the COVID-19 pandemic. For example, we had medical student and lecturer from our UMP, and we have the attending of the primary healthcare such as district hospital. And we have specialized healthcare with two big center of specialized healthcare such as the University Medical Center and the Hospital for Tropical Disease in Ho Chi Minh City. And we have the effective health policy on supporting vaccine production and supporting medical supplies. And we have the COVID-19 patient with community contributions, such as we develop and delivering effective vaccination, and we deliver basic prevention for COVID-19. And first lesson that we have successful activity from our UMP. We play a key role in the COVID-19 intensive care center under UMP at City International Hospital. We provided support at the COVID-19 intensive care unit located at Oncology Hospital 2. We organized and implemented the community-based care model for COVID-19 case. We participating in community sample collection for COVID-19 testing. We contributed to the COVID-19 vaccination teams. And this is the example of the standard model for COVID-19 patient care in the community. First, pillar 0, we provide and update the list of COVID-19 cases, and we help them to remove their disease at their home. And if they get more severe disease, we will have the outpatient emergency care to deliver patient to the hospital to be treated. And then after that, they get recovery. And from the primary healthcare, we practice like under WHO guidelines. For example, we maintain essential healthcare service. We support effective public health measures. We diagnose COVID-19 case and ensure proper referral processes. We manage mild and moderate COVID-19 case effectively. And we have very strong specialized healthcare. We have two big centers. The first is the University Medical Center and Hospital for Tropical Disease. We handle effectively severe case, treat, and we use advanced medical technology, for example, ECMO or ventilator, and we apply the protocols for patient care in intensive units. And we have the activity of research and clinical trials. That is the contribution to the development and treatment protocols and clinical trials for new drugs and vaccines. And we discussed to each other of case study, especially any notable recoveries or innovative treatment. We support for lower level hospital and to telemedicine. And this is the pictures of telemedicine of specialized on supporting. And Ho Chi Minh City leads the encouraged doctor and medical staff at the intensive care of COVID-19. And we have community, maybe late, but effective vaccination. And Ho Chi Minh City have 59 COVID-19 vaccination points around 22 districts or towns. And we deliver basic prevention for community, like wash hands, wear masks, and sanitize hands with alcohol-based solution. And in the future, maybe we'll have a new disease caused by virus or bacteria that can cause another epidemic. And these disease maybe need research and develop in emergency context. And maybe the name is the disease and the disease is defined by WHO, and it can cause another pandemic with 20 times deadlier than COVID-19. And disease is caused by unknown pathogens, but can potentially cause an epidemic. And this term is not so new. It's formalized by WHO in 2019. And scientists around the world are talking about this. And as of now, it's not clear where the disease could emerge from. And it's a big challenge to prepare for fight against disease. So from the lesson from COVID-19, and this is how we preparing for future pandemics. And I think we have maybe 5 recommendations. First, we will have to build sustainable capacity for epidemic response, both within and outside the government. We can accelerate developing, producing, and distributing vaccine, medicines, and testing. We recognize the importance of expertise and centrality in ensuring high effective communication. We can focus on building and maintaining public trust. We must strengthen and invest in government and international pandemic response efforts. So I would like to conclude my presentation. We can plan for unpredictable future pandemic threats, and we can enhance global cooperation in pandemic preparedness. We must invest in rapid vaccine and medicine development. We can strengthen public health infrastructure and response system. We must ensure transparent communication to build public trust. And we have to prioritize long-term resilience over short-term solutions. That's end my talking. Thank you for attention.
Thank you very much, Dr. Nguyen Tin Kam Hom. Your comprehensive and very systematic approach to share with your experience with us. So now we'd like to hand over to Dr. Tam, our co-chair. Tanma Sensei, over.
Thank you very much.
Thank you. So let's move on to the next presentation. So next speaker is Dr. Nguyen Phu Chau Duc from Hue University of Medicine and Pharmacy in Vietnam. Dr. Chau Duc, yes, please.
Yeah. Yeah, good morning. Can you see my slide? Yeah. It's such an honor to be here with great sensei and colleague. I'm also graduated. I got my PhD course in Tokyo Medical and Dental University under supervisor the Professor Keiko Nakamura. Once again, I'm very grateful and honored to be here for sharing the emergency and re-emergency infectious disease, how we got to COVID-19 and more insight from Vietnam. What are emerging and re-emerging disease? Emerging disease are those newly appearing in the population or rapidly increasing in incidence or geographic range. They fall into 3 categories: completely new disease, previously isolated disease now spreading. Disease newly recognized due to the discovery of the causative agent. Examples include AIDS, Ebola, and Lyme disease. Re-emerging disease, on the other hand, are those that were one major health problem, decline, but are now becoming significant again. Notable examples include malaria, tuberculosis, cholera, and influenza. Some notable examples of the re-emerging disease include malaria, as you see, malaria, tuberculosis, cholera, pertussis, influenza. The disease remind us that even with medical advancement, we must remain vigilant against those threats. This highlight isolated the emergence and re-emergence of viral disease over the past few decades. As you can see, we face numerous challenges from HIV/AIDS in 1980 and to the recent COVID-19 pandemic. Its outbreak has taught us valuable lessons in disease management and prevention, shaping our current understanding and response strategy. This timeline illustrates the devastating impact of COVID-19 on global public health from its initial outbreak in Wuhan, China, to its rapid spread worldwide. The pandemic overwhelmed healthcare system, disrupted economies, and claimed millions of lives. As we reflect on this challenging period, we must acknowledge the importance of public health preparedness, international cooperation, and equitable access to healthcare. The lesson learned from COVID-19 will guide us respond to future health crises. The COVID-19 pandemic had far-reaching effect on public health, not just in terms of the immediate impact of the virus, but also the long-term consequences on healthcare system and society. It has exposed vulnerability in our global health infrastructure and highlighted the need for robust preparedness and response mechanisms. So research has shown that SARS-CoV-2 infection can have potential long-term effects on various organ systems. These include cardiovascular, respiratory, and neurological complications. Understanding the long-term impact is crucial for developing comprehensive treatment strategy and support system for COVID survivors. To effectively address the long-term effect of COVID-19, we must understand the underlying mechanism. Current research suggests that persistent inflammation, autoimmune response, and direct viral damage may contribute to the long-term effects. This knowledge is essential for developing target therapy and prevention strategy for future pandemics. These maps highlight the global distribution of infectious disease during the first quarter of 2022. The observed pattern may be influenced by factors such as weakened public health infrastructure, increased international travel, and altered population immunity for provide following the COVID-19 pandemic. This graph illustrates the global reported measles case from 2000 to 2023. The recent surge in case is alarming and indicates a potential resurgence of the vaccine-preventable disease. This finding underscores the critical role of the substantial high vaccination coverage, particularly in the post-COVID-19 era. The COVID-19 pandemic has significantly disrupted routine immunization programs worldwide. This chart illustrates the decline in measles vaccine coverage. The blue line represents the first dose of the measles containing vaccine, while the orange line shows the second dose. This decline could lead to dangerous outbreaks in the future, emphasizing the need to strengthen and restore immunization programs. Interestingly, we observe a sporadic surges in dengue infection during the second year of the COVID-19 pandemic. This highlights the complex interplay between different infectious disease and the importance of maintaining vigilance across all fronts, even during the major pandemics. The increasing global burden of dengue fever since 2022 highlight the far-reaching consequences of the COVID-19 pandemic. Disruption to public health system which underscore the significant impact of the pandemic on global TB control efforts. Vietnam has implemented various preventive healthcare measures and strengthened its public health system to combat emerging and re-emerging disease. The efforts include improving surveillance system, enhancing laboratory capability, and strengthening cooperation between different health sectors. This timeline saw Vietnam respond to the COVID-19 pandemic from January 2020 to January 2024. Vietnam's success in managing the outbreak were due to early intervention, effective contact tracing, and strong community engagement. Key events include the first case in Ho Chi Minh City, the Da Nang outbreak, and the emergence of Delta and Omicron variant. Three key factors for this successful are early intervention, contact tracing, and community engagement. The COVID-19 pandemic had had a significant impact on Vietnam's public health landscape, including the resurgence of dengue fever, disruption to vector control program, weakness surveillance system, and increased healthcare burden have contributed to the elevated rate of dengue transmission and severe disease. In 2022, major outbreak in Vietnam, with over 2,000 suspected cases and 5,000 confirmed cases, severe at a stark reminder of the potential consequences of disruption to immunization program. The COVID-19 pandemic may have exacerbated this issue by diverting resources, disrupting healthcare services, and increasing vaccine hesitancy. As you know, the COVID-19 pandemic disrupted healthcare system worldwide, leading to decline in TB diagnosis and treatment. Unfortunately, this distribution has severe consequences, as evident by the re-emergence of TB in many countries, including Vietnam. And I myself, one year prophecy study conducted in Pediatrics Department of West Central Hospital, a tertiary hospital in Vietnam in 2023. We identified 36 children with tuberculosis. Before 10 years, we just identify around 5 or 10, but last year, only in 1 year, the number is increased. And this finding underscore the alarming resurgence of TB in Vietnam post-COVID-19 pandemic. To better prepare for future outbreaks, public health care system need remodeling. This includes improving surveillance, enhancing laboratory capability, and strengthening cooperation between different health sectors, as Professor Kenos mentioned before. And these improvements are crucial for early detection and effective response to emerging infectious disease. International collaboration is key to facing emerging and re-emerging infectious disease. By sharing knowledge, resources, and the best practices, we can create a more robust global health security network. This collaboration is essential for effective disease surveillance, research, and response on a global scale. Finally, let's look at how we can apply the lesson learned from COVID-19 pandemic. This study includes enhancing surveillance for early detection, adapting surveillance for early detection, adopting flexible research approach, clarifying emergency definition, combating stigmatization, ensuring equitable vaccine distribution, and rebuilding trust in science, focus on transparent communication to restore public trust in health recommendation and counter misinformation effectively. Yeah, thank you for your attention.
Thank you so much. Thank you for the very informative presentations. Yes, I would hand over to Yamamoto Sensei. Yeah,
Thank you. Yes, thank you very much. So our next speaker is Professor Arongkong Phengsabang. Arongkong Phengsabang, Dean Faculty of the Public Health, University of Health Sciences, Laos. Professor Arongkong, you are here? Okay, great. The floor is yours.
Yeah, Okay, can you open my slide? Professor, can you hear me?
Yes, I can hear you. Secretariat, can you open the PowerPoint slide of Professor Arongkong?
Yes.
Yes, please. No.
Okay.
I just I need to ask the secretariat.
Okay.
Or can
Please,
you do by yourself?
Okay. Did you see my slide?
Oh, unfortunately we cannot see it. Can I ask the 事務局 secretariat to help him to open his slide? Oh, nobody answered. Oops. 塾先生、そっちからあれですか、スライドを見せてあげれるんでしょうか。
The speaker is supposed to open share your slides on your own. However, I wonder if we could prepare for the PowerPoint for the presenter.
I try to open my slide. If I just okay, I cannot manage it. Please help us. Tell the secretary to help us.
Okay.
Okay, wait a moment.
I'm afraid we don't have his slide.
Oops. Oh. What's up?
Okay, so Yamamoto sensei, maybe we proceed to the next speaker, and while the next speaker is speaking, maybe
Okay.
yes. Okay, so please.
Maybe the fifth speaker can talk. Yeah.
Okay. So.
Yeah, let's move on to the.
Okay, I agree.
Yes, thank you. So let me introduce the next speaker from Dr. Foren Charikena from University of Health Sciences, Cambodia. Dr. Charikena, please start your presentation.
Thank you so much. So please wait a moment while I'm sharing my screen.
Yeah.
Okay, so good afternoon, everyone. My name is Chan Lakhana Phang. I am the director of Rodolphe Meyer Laboratory, Cambodia, and also a lecturer and researcher from University of Health Sciences, Cambodia. So first of all, let me start by acknowledging the organizers for the invitation, and as well as the rector of University of Health Sciences, Cambodia, for allowing me to share with all of you about our work entitled Transforming Challenges into Opportunities During COVID Pandemic, the lesson learned from Rodolphe Meyer Laboratory, Cambodia. Just for your information that before COVID pandemic, Rodolphe Meyer Laboratory is the research lab of university working on various research projects under technical and financial support of Meyer Foundation in France. The training on the research was provided to only master degree students, and very few people in the university knew what we were doing at that time and what we were capable to do regarding molecular biology testing at that time. Our biosafety level 2 plus facility and capacity in molecular biology testing was built since many years before COVID-19 were first found in 2019. So in 2020, the capacity building for COVID molecular testing was conducted among the lab team and with support from our existing national and international partner. Now, Rodolphe Major Laboratory became the member of National Laboratory Network, conducting many research projects related to the infectious diseases, including COVID-19, and we have coordinated and published scientific papers about piloting EQA program of COVID rapid test and hold ISO certificate for molecular diagnostic. That is why, based on this experience, I would like to emphasize and share with all of you 5 main points that must be embraced together without specific order. They are safety, the right team building, collaboration, technology innovation, and quality assurance. These are what we find important to be prepared for the next outbreak. The biosafety level 2 plus facility of Rodolphe Major Lab was built in 2005 and renovated in 2017. Our staff are already familiar with the biosafety and biosecurity principle, and they already have knowledge and skill in working in such containment. That allow us to adapt faster to the workflow of COVID pandemic by just doing some additional activities such as the risk assessment for COVID testing, the facility assessment by the expert to be specific by WHO, and by updating the workflow for COVID testing and the flow for the waste disposal to mitigate all predictable risks. So COVID pandemic taught us to learn how to mobilize the resources effectively. The COVID testing team was built and nominated, and the technical training first was provided to the team leader, and after that was provided among the team immediately to conduct the testing. However, the biggest challenge at that time is the limited knowledge on the disease, as it was very new to everyone, and everyone was so scared and tried to escape from the testing. So I would like to take this opportunity to thank to my team. Despite the much extra workload, we help and supported each other. Sorry. We help and supported each other, and we work every day from early morning until late night, no weekend, no day off until the pandemic is over. So this act was visible and recognized by the top leaders of the universities, as well as the Ministry of Health and the government. And at the end, our efforts were paid off. If you still remember what I just said earlier, we could not make it this far without the support from the collaborator, the existing collaborator, and our partner. That is why we think that maintaining the good collaboration with the existing partners and extending the collaboration with the new partner are one of the key for success and for the sustainability. So thanks to the collaboration that we have before and after COVID, from one year to another, our goal is to update the testing method that we have for new pathogen, as well as to use the existing resources to update our testing platform and build our capacity in testing to be prepared for the new outbreak while maintaining what we already have. So before COVID, we did only PCR along with some immunological testing. But after COVID, we upgraded our lab capacity for sequencing and automatic PCR that could be useful for the urgent testing. At the same time, we maintain our capacity in pharmaceutical testing because it is the unique test in Cambodia. And once again, we update our capacity while maintaining what we already have. So let me end my presentation with the last component that raises the recognition of our lab to the international level is the certification of ISO 9001 for quality management system in molecular diagnostic. The internal quality controls and the external quality assessment are important. By knowing our gaps, it allows us to improve for better. The successful implementation of quality management system allow us to assure our workflow from receiving sample until reporting result. It doesn't mean that we have no mistake, but it helps us to track the error and provide the corrective action on time, making sure that the results produced by Rodolphe Meyer Lab are reliable and trustable. So these are the two publications describing the result of the piloting EQA program of COVID rapid tests in Cambodia coordinated by us. And another paper from our funder in Australia describing the whole program of EQA COVID-19 antigen test quality assurance that were implemented in Cambodia, Laos, Indonesia, and Papua New Guinea. So I would like to thank you for your attention, and I welcome to all questions and comments after the presentation. Thank you.
Thank you for Dr. Kena. Yes, we sure to have time to discuss with over your presentation. Thank you. So over to Yamamoto Sensei.
Yes, thank you. So our next speaker is Dr. Kokoruda Agyun Wahu Purunamasidi. Oh, it's from the University of Udayana. So
Udayana University.
Udayana University. Okay, so please, floor is yours.
Thank you, Ralph. It's my thank you, Prof. Doctor. Yeah. Good afternoon to Professor, Medical Doctor, and all participants who are joining this Zoom meeting. My name, my name is a little bit Indonesia, so it's difficult to say that. Cokorda Agung Wahyu Purnamasidi. You can call me Wahyu. I'm a lecturer from Udayana University, from the Tropical and Infectious Disease Division, and today I will share about insight gained from the COVID-19, readying to our self for the future pandemic. This is my curriculum vitae, and this is the objective of this presentation. One is to understand key lessons from the COVID-19, explore initiative, and understand the key factor. And the fourth is identify challenge and the solution. And first, we have know that the PRET is an innovative approach developed by WHO to enhance pandemic preparedness by utilizing the system capacity and knowledge already available in a country. And PRET is designed to apply lessons learned from the past pandemic mistake. The key aspect in planning PRET is detection, investigated and mitigation, community trust, expanding reach and improving the quality of healthcare facility, ensuring good access to pandemic contrastments such as vaccine and coordination at all levels and across multiple sectors. And next, effective decision making by policymakers. This is the second of the presentation. In effective decision making in Indonesia faced several challenges during the COVID-19 pandemic. Delayed pandemic response first, and then second, lack of the preparedness of the and funding for the emergency and research. And then controversial government statement. This caused the confusion and mistrust among the public future complex pandemic management. We have the solution that to apply the good organization planning and enhance communication strategy. To address this issue, solutions were implemented adopting the comprehensive planning framework, such as PRET module in the module 1 from the WHO, and improving community strategy, strengthening testing and contact tracing with the proper funding and training, and establishing a robust healthcare system. The third is strengthen community safeguard. Strengthen community safeguard by enhancing trust, improving communication, and countering misinformation. Limited public literacy. The cycle begin with limited public literacy. This make it harder for people to understand public health message and scientific information, leaving them more vulnerable to misinformation and less likely to follow official guidelines. Second is public misconception, and the third is public government mistrust, ineffective program implementation, and the second is breaking to the cycle. To breaking the cycle, intervention need to target multiple point stimulation. These include improving health literacy through accessibility education, address misconception with clear cultural appropriate communication, build trust through the transparent consistent engagement, and design program by community input and feedback mechanism. Fourth is the significance of the surveillance and investigation in the address emergency infection. The key is the early detection, prevention, and treatment of new infection. From the monitoring infection disease is the strategically important approach to safeguard public health and mitigation the risk of future outbreak. These preventive measures necessitate the collaborative support of the government, communities, and the individual to foster the healthier and the safer future. Key indication in this monitoring process may include epidemiological surveillance, laboratory capacity, community education and protection, global cooperation, and surveillance of zoonosis and the environment. So next is how about the surveillance of the main pillar in early detection. The first is identification of the earlier case allow for the quick response to prevent future spread. Understanding the epidemiological pattern of the disease provide the insight into the spread dynamic and the risk factor, evaluation of the effectiveness of the medical intervention, preparedness of the globally integrated surveillance system, enable cross-country information exchange to the comfort shared threat. This vaccine developed as the ultimate strategy to combating pandemic. One of the most widely recognized key strategy is combating a pandemic is the development of the vaccine, which can prevent the spread of the disease and protect vulnerable population. In COVID-19 pandemic situation, the rapid and effective development of the vaccine has proven to save millions of lives, accelerated economic recovery, and restore social life. Therefore, investment in the vaccine research in the global collaborative is essential to ensure preparedness for the future pandemic. The challenge of developing vaccine itself include, first is time. A vaccine developed usually takes many years, but urgent situation like pandemic may require faster process. Second, in ensuring safety and efficacy. And the third, distribution of logistic and genetic, the last is genetic variation of the pathogen. Change of the pathogen genetic can impact the vaccine effectiveness, unfortunately. And next is advancing human resources for emergency infectious disease management. During the COVID-19 pandemic, we witnessed the tragic reality. Numerous healthcare workers lost their life due to overwork and inadequate protective equipment. This hard lesson that taught us that the critical importance of the proper workplace management. Looking for the healthcare workplace management, we have three crucial areas for focus. First is workplace investment, second is working condition, and the third is regulatory support. And six is improve the accessibility of the activities of the healthcare service. The COVID-19 pandemic revealed how crucial it is to have robust healthcare system in place. Let me walk through our three main strategy to improve healthcare service. First is quality care system. Develop and update clinical guideline, implement standard operating procedure, enable community-based healthcare access, and provide outreach service. And the second is diagnostic and remote service. Support access the diagnosis service, ensure access to essential medication, and utilize digital and telemedicine platform. Third, it facility preparedness. Maintain the essential health service during the emergency, map and utility private sector research, priority access to quality insured therapy, and last is enable participation in clinical research. And seven, in increase financial support for sustainable investment in the multi-sectoral health system. We know that funding issue and challenge that Indonesia faced during the COVID-19 pandemic is first, there was delayed distribution, and second next is mislocation, and then corruption of allegation and inefficiency. But how funding should have been structured now? First is healthcare system strengthening, hospital capacity expansion, testing and tracing, public health measurement, vaccination program, public awareness campaign, and research and development. Local vaccine development data management system. This is must be improved by the Indonesian government and Indonesian medical service. Thank you, Prof, for your time, for opportunity. Maybe in the next we have session. Thank you.
Thank you very much, Dr. Wafu, and your comprehensive pictures share with us. So we would like to move to another speaker. So Professor Arongkong, we are going to fix it to your PowerPoint. So we would like to ask you to wait until the last speaker. So I would like to ask Tanma Sensei to hand over to you.
Okay, thank you. So the next speaker is Dr. Brigida Saigahan Solomon. I hope I can pronounce your name correctly. And they are from Mongolian National University of Medical Science, from Mongolia. Dr. Solomon, please.
Hello, everyone. Could you see my slide?
Yes, yes, I am.
Okay, let's start my talk. First of all, I would like to thanks to attend this annual ERISE Symposium organized by AMED and International University Health and Welfare. My presentation topic is the effect of pandemic on the national TB program in Mongolia. First, I would like to introduce the national TB program infrastructure in our country. It's classified, subdivided 3 levels. First level means some level. It's a kind of rural area level. Also, second level is we call the province and district level. In our country, there are 21 provinces and 9 districts. 9 districts. Also, third level is a kind of city hospital, national and central hospital usually taking care in this level. Actually, in every levels, there are TB research and surveillance department, also TB clinics. Unfortunately, our country, Mongolia, this map, there are high prevalence and incidence of the TB in the population, especially per 100,000 population per year. Also, recently, multi-drug resistant TB has increased. The incidence rate of the TB is 3 to 4 times higher than Western Pacific region, also world average. Also, multi-drug incidence of multi-drug resistant TB is 5 to 6 times higher than regional and world average indicators. Also, if you can see the childhood tuberculosis, TB, it's also very high, 3 to 4 times higher than other region and world, other international categories. If you can see the left graph, compared to the two neighbors, China and Russia, TB incidence is 8 to 9 times higher in Mongolia, in our country. This is a national TB program summary, last more than 60 years. This is a number of cases, also incidence rates of the TB. If you can see the graph, we have two nationwide early detection campaign in 1962, also 1985. After this nationwide early detection campaign, number of the TB cases dramatically reduced. Also, our government, Mongolian government, Ministry of Health, has implemented several strategies against the TB. One of them is a DOTS strategy. Also, I have to mention support from the international organization, such as more than 60 years support from the WHO, more than 20 years support from the Global Fund. This is COVID-19 surveillance and responses. Actually, in our country, there are 8 to 9 big outbreaks, big waves. The more than 1 million cases registered, diagnosed by the COVID-19 by the 1st of October 2024. Also, more than 2,000 deaths are registered in our country. However, if you can see the one indicator of the death, CFR, case fatality rate, it's 0.22. It means it's 2 times lower than the Western Pacific region, 5 times lower than worldwide. Measurement against the COVID, it depends on the surges. This is COVID-19 variants. It's similar to other countries. Wild type, alpha, delta, omicron surges, especially also omicron waves subdivided into the 6 to 7 subvariants. During the COVID, we have nationwide two lockdown. Also, UB capital city level lockdown we have 2 times. Especially this quarantines, our government implemented before early stage of the early period of the pandemic. This is a vaccination campaign against the COVID-19. If you can see the starting date of the vaccination against the COVID-19, before beginning of the early every stage, every surges can start the vaccination campaign. Actually, we have a choice for the vaccination, 4 kinds of vaccine. Also, both dose, 3 kinds of booster doses available. This is TB cases during the COVID-19. New TB cases were reduced during the 4 times nationwide lockdowns, the peak of the COVID-19 waves, and the national holidays. An average number of the TB cases is around 3,000 pre-pandemic and around 2,000 post-pandemic. Also, drug-resistant TB cases is reduced after the during the COVID compared to the pre-COVID. However, the treatment success rate was conserved more than 70%. It means there was no difference before COVID during the COVID. Also, we calculate the impact of the COVID-19 on the national TB programs. Human resources, also physical resources, mobilization have been very high during the COVID. You can see the deployment percent for the COVID-19. Also, ACF, active case finding is partially done during the COVID, especially in the nationwide capital city level lockdowns. This ACF is stopped. TB screening was only 20% during the COVID, but before the pandemic, it was 30%. It means TB screening was reduced by the 10%. This is our government, Ministry of Health, made several several plans during the pandemic to sustain the national TB program. This is a conclusion, my talk. Today, I would like to conclude the effect of the pandemic on the national TV program, it it has two kinds of influence, positive and negative influence, because everybody now know positive influence because every measurement against the COVID-19. So I would like to say negative impact. Today, in the slide, I showed the negative impact because human resources, also TB care bed, some facilities deployed to the COVID-19. It's a kind of negative impact. Also, who have, during the pandemic, who have diagnosed the new TB cases, anyone couldn't reach to the clinics, couldn't take care against the TB. It was also a negative effect of the pandemic on the infectious disease such as tuberculosis. Thank you very much for your attention.
Thank you, Dr. Thurmond. Thank you for your very concise, very elaborate slide. Thank you so much. And I unfortunately, Dr. Sonbonsu from Laos has to leave the session due to some urgent problem. So maybe now we should proceed to the discussion sections. And Professor Yamamoto, I will hand over to you.
Thank you very much. And first of all, I really appreciate all speakers to share your views and lessons learned. We have heard that we have a common lesson and learned regarding the surveillance, health workforce, and support to them, capacity building, including laboratory, R&D, or risk communication and decision making, and also including the primary health care, how to sustain primary health care, including TB management. So, and also we have a lot of common recommendations we heard, while each country has a different situation and different difficulties. So, having said that, is there any questions from the speakers to other speakers, or is there any comment from the speakers, or any comment from your side? Oh, don't hesitate that. So while you are so quiet, so in that case, we heard that many speakers talk about the collaboration in the Asian region for the future. Oh, I see some speakers. Oh, okay. So you are.
Yes, so once again,
Okay.
my name,
Yes, please.
Lakana from Cambodia. So actually, I don't have the question for the presenter in the presentation from different from other country, but I have one question regarding the opening remark, because one professor talking about vaccine development, and in Cambodia we don't have enough capacity and resources for that yet. I would like to know your suggestion about how we should start regarding the vaccine development. And if we import the vaccine from other country, how can we
Thank you very much. We missed your last part, but you asked the how to work, develop R&D and vaccine development as well as regulatory science, right?
Yes, yes.
Yes, okay. Thank you very much. Honestly, that's exactly what I would like to discuss with all of you, because we heard a lot of comment about collaboration and support each other in Asian country for the future. So what concretely we can collaborate, and what kind of mechanism or framework we need to enhance our collaboration? And one area is exactly what the Cambodia lady said, that Dr. friends that the R&D and vaccine development. So is there any comment from the speakers or share your idea?
Professor Yamamoto, I'm
Yes.
sorry for your interruption. However, Dr. Zhang from Hanoi Medical University has to leave so in 10 minutes or so. So maybe we should ask his last minute comment. Dr. Zhang, please, if you have any question or comments or suggestion.
Yes, please.
Hi. Thank you for accommodating my schedule and having me to speak.
Okay, thank you.
Sorry, can you hear me now? Yeah.
So, any words or any comments on the Yamamoto Sensei's last question? How we can collaborate globally in the context of the pandemic?
I think the question is is a very important one, and knowing that we have different areas of potential collaboration. We have a clinical trial, we have the disease management, we have the epidemiology and preventive measures and so on. So I think that in general we want to create the line of collaboration in different in that different specialties. I think for example, the International Health and Welfare University could have a focal point in different areas of expertise, and then we can create the different networks from different universities that have a country represented in this ARISE framework. I think that's one important. That's one point that I would suggest is to really develop collaboration in different expertise. The second, I think is also important is to involve the graduate students, whether they are the PhD students or they are residency or other type of graduate students, because ultimately we are the one who will initiate the collaboration, but who will sustain it beyond the ARISE lifetime, right? That would be the graduate students and our future generation. So I think that the sooner we could involve them in different type of activities, the better. So I think those are my two recommendations. Thank you.
Thank you very much. That's a very informative and very exciting. So, is there any comments? Yes. Oh, Dr. Solomon or Solomon, Dr. Solomon or Solomon from Mongolia. Over to you.
Yes, thank you. I have only one question from the Dr. Lee Ming Jiang. Yeah. Hanoi Medical University, Vietnam. Because it was very similar from your country, also compared to in Mongolia, because beginning period of the pandemic, human resources deficiency, especially the nurses, is occurred. Also, this problem is still having. We have still having this kind of problem in our country. But in your slide, you beginning of the period of the pandemic, you have a lot of human resource deficiencies, but you already decided during the pandemic. Could you share your experience to us how to solve these problems, Professor? Thank you.
Thank you. First of all, thank you for pronouncing my name. Not many people outside of Vietnam pronouncing my name in such a wonderful way. Thank you. And I'm sorry that I can't pronounce your name in a similar manner. And thank you, Professor Solomon from Mongolia, for your question. Yes, I think the COVID, we're very proud of our primary care system, but during the COVID-19 pandemic, it exposed that it didn't work as we would like to. There was a lot of the insufficient capacity at the primary care level to take care of the COVID-19 infected individuals before their arrival at the hospital. I think that's a very important point. We can't sustain any efforts. As Dr. Kasai mentioned, we can't increase the beds forever, right? So we have to be able to manage the sheer number of infected individuals, most of them at the mild or even non-symptoms level at the primary care level. So I think that's one important point. The second is that once the patient arrive at the secondary or tertiary care level, or even in critical care, we don't have sufficient trained physicians, nurses, and other paraprofessional, other healthcare professional to take care of the patient. For example, we didn't have enough trained psychologists to provide the mental health care for healthcare workers, for family members, and for the patient themselves. And also, we didn't have enough the critical care physicians to take care of the critically ill patient and nurses as well. And our colleagues from infectious disease department from Hue and Ho Chi Minh, they can attest to that. So that's the second lesson that we learned. The third lesson that we also learned is that even when we move the healthcare workers, we deploy healthcare workers and students from other provinces to the hotspot area, right? We have to prepare them better. We have to create the coordination, the collaboration mechanism between the local authorities, between local healthcare workers and the healthcare workers who were deployed from other areas. And that collaboration didn't work perfectly at the beginning. And that's why there was some significant waste of resources and waste of human resources in many of the areas. So those are the three lessons that we learned. What we did well was the government was able to, and also with the collaboration of university, were able to mobilize a lot of the healthcare workers, whether they were physicians, faculty members, or students. I think the students really play a very important role in supporting the areas where the critically shortage of healthcare workers. So I think the government did in that area very well. And also another area that we did very well was to produce quickly the treatment guideline and also the other guidelines that follow WHO standards. So that's something we were also very proud of in terms of our response. So in short, I think to answer your question, I think the important thing for me is to now think about how we can train our students better, knowing that what would be needed in the future pandemics, how we can train our students, whether they are medical or nursing or other kind of professionals better in order to prepare for what will arrive in the future. Thank you.
Thank you very much, Dr. Lee Mingyang, for your valuable experiences to share with us. So, but thank you very much. So, but we have still remaining a question from the Huen Charing Hana, some from the Cambodia about R&D and the capacity building. Is there any comment from the speaker side? Regarding the R&D, each country has a different capacity, including private sector, right? And the resources is different. But the most important things is the joint training at peaceful time, including the university is should be a key institute for the evaluation and also education. And so this program, ARISE, is intended to expand international collaboration, international clinical trial. So if we could successfully set up the good training, including this symposium, and come up some opportunity for the joint clinical trial, even in a small scale, that would be great. And on top of it, I understand the regulatory science area, the PMDA, the Japanese regulatory agency, and right now has some program work together with Asian countries to train the regulatory science experts. That's also very important to, how can I say, develop the capacity of the private sector. It's not easy, and it's not our academia side. It's not necessary that we can do a lot from the academia side. But I think that Dr. Kasai is here. So, I mean, WHO and such an international agency also could take some role to enhance the capacity of R&D. Not necessarily like a original new medicine, but even in the generics, we can work together to come up to develop and produce, the generics and so on. But any other additional comment from the speakers or other side? Tanma Sensei, do you have any additional one? Because you know that you work so hard on the HIV/AIDS area, other infectious disease control area. So if any other comment from your side or other doctors.
Yes, I have some comments. Before I introduce my comments, but I would like to invite the audiences and to post your questions and comments on the QA messages. So my question is that to speakers from Vietnam. You experienced the SARS epidemic, as Dr. Kasai mentioned in his talk, and I wonder how the SARS epidemic's experience, lessons learned, so-called, could facilitate the response to the COVID-19 pandemics. So maybe first, could I ask to Dr. Kam Phuong from Ho Chi Minh City University.
Yes, thank you for the question. And my lesson from COVID-19 is that from the first time we have detected COVID-19 case, we want to isolate them, and we want to prevent spreading the COVID-19 virus from the among people, among communities, and maybe it's not successfully because it can spread among many areas in our country and into other countries. And maybe in the epidemic, you can show that the number of severe case, symptomatic case in Ho Chi Minh City is increased. And but after that, if we have the effective vaccinations and we have policies for monitoring of COVID-19 case with mild, not severe disease, and if our healthcare worker, we must concentrate on treating for severe case and with when they need intensive care. And if we get collaboration and we get help from our community and from our government, we can maybe post off the COVID-19 pandemic. And so I think the RAD and of vaccine and we full cooperation with
I think we had at the early pandemic, COVID-19, the early pandemic, COVID-19 pandemic, we had successful because in the early pandemic, we had the we had decision, the good decision to tracing for the COVID cases, and after that, because of the effectiveness of vaccination coverage, and I think the most important is because of the society support, the support from the society. We have a lot of medical students volunteer to come to the front line. We at the and at the front line we also we have the people, volunteer people. They volunteer to support the oxygen. They support the delivery for the patient from the outside to the COVID sector. And the most important, another important thing, I think, the stigma. Because of the stigma, we the people don't believe to the at the early, I mean at the early stage, the stigma is very important. We have to combating with this, and we have many platform as well as in from the society media platform to combat the stigma. So the people believe to the government, believe to the doctor, and we together can decrease the COVID-19. Thank you.
Thank you for your comment. So it seems that the early case identifications or the isolation of the patient and then under the infection control will be a kind of something we severely learned from the pandemic of SARS. And however, the SARS epidemic was quite short time period. So we didn't have enough time to develop some vaccines or medicine. So that is why the R&D area would be the new things that we should learn from the COVID-19 pandemic. The most challenges we faced that. So yes, over to Yamamoto Sensei.
Thank you very much. And regarding the better preparedness and responses for the future pandemic, also we need to discuss, think about the new information sharing method like SNS and other way to do so. And on top of it, and all countries improve or enhance the capacity of telemedicine or using another digital technology to support people. But still is even in Japan is on the way, middle way to go. So is there any innovative idea for the future preparedness and responses for the pandemic, or again, is there any way we can work together or share with your views to all of us? Is there any comment from your side or speakers?
Oh, I had some
Yes,
comment.
yes, please. Thank
Yeah.
you.
Maybe for the future pandemic, maybe we must detect, diagnose. We have the test to confirm, diagnose early, and we can collaborate to many countries and to develop the test and how to get the infection control effectively is very important with the caused by virus or by bacteria. And then how we can apply treatment effectively for patients and R&D vaccination and the drugs is very important. And maybe we get the help from our government, from the community for supporting healthcare worker to struggle against the pandemic. That's it on my comments.
Thank you. Thank you very much. So is there any other additional comment? Or if you would like to raise it. Oh, okay. Yes, please. Solomon-san, Tensei. Oh, Dr. Solomon, please.
Okay, thank you, Professor Yamamoto. Because telemedicine, it's a very a good question, I think, because Mongolia has very big territory, very quite big. Also, we healthcare system divided rural and city level area, especially in the rural area. Primary healthcare workers, they they have to use the telemedicine every day. We have to we have to improve this capacity, especially in the rural area. It's very important, I think. Also, just 3 years ago, during the pandemic, our government, Ministry of Health, they started the early detection nationwide campaign in our country. Actually, in this campaign, our government just try to use the registration system, including rural and city area. I think it's a very important because to creating big data from the our population, maybe a few years later, uh, we can organize our future plan, also strategy based on this data. Also, I would like to share my one comment, especially on the risk communication, because in every country, maybe I think it's a same problem. We have same problem on this issue because of the vaccine hesitancy. Vaccine hesitancy, especially the COVID-19 vaccine. There is some risky people. They don't want to get the vaccination, especially the routine vaccination. They always avoid to take routine vaccination, such as MR, measles and rubella vaccination. That's why last 2 years in our country, some outbreak of measles occurred. Maybe in some country it's also very same issue. That's why we have to we have to take attention on the risk communication, especially on the population and community about the good uh, uh, information, especially on the vaccine, about the vaccine. Also, our government also, our government updated immunization law. Three kinds of immunization vaccine added in the new update. HPV, PCV, also hepatitis A vaccine. But according to this immunization law update, we have to we have to do the HPV vaccine in the younger generation. But still, we have a very big problem from the people, our population. They always argue against the vaccination campaign, especially on the HPV vaccine.
Okay.
Also,
Okay.
finally,
Yes, please.
I'm sorry. Finally, I just would like to say this, yeah, that's why we have to do together, especially the joint research work, especially
Right.
on the vaccine technology, new drug technology, because this AMED program is supported clinical trials on these projects. That's why I would like to say this symposium, this meeting, this program activities are very important for us collaborating, also uh, including the conducting the joint project together in the future. Thank you very much.
Thank you very much. And we have one more comment from the Professor Huen. Over to you. Huen Chandikana. Dr.
Sorry,
Chandikana-san.
I
Okay,
thought it's
over.
not me.
Maybe my
Okay.
pronunciation is so bad. So
So just to continue with the comment from Professor Solomon, sorry if I pronounced your name incorrectly. Regarding the vaccine, it actually is very important because it related to the cost effectiveness. By implementing the vaccine program, it can cut down the cost. However, the effectiveness is very big comparing to the cost and effective after the people got infected, right? And one more thing I would like to emphasize about how we use the technology to predict the future trend. For example, data science that help us to see the how the disease develop from time to time, and while waiting for the disease X outbreak, like the speaker told Dr. Huang mentioned about disease X, we don't know what will happen. So I think that using the technology to help us to predict and to predict the future trends is also important. Thank you.
thank you very much. So, it seems me time has already, we have consumed our time, but it's not easy to summarize such a rich presentation and roundtable. But obviously, we need to continue to learn each other and communicate each other. But at the same time, regarding R&D, which is the main topic of this program, near future, we should enter next stage to implement the joint clinical trial or even a small scale to come up, improve our capacity of R&D altogether and to contribute to the society, the preparedness and responses of the pandemic. So I would like to close this session together with Tanuma Sensei. Thank you very much for joining. So I would like to hand over to Dr. Professor Shimokawa Sensei to finalize and close this session. Over to you.
So thank you very much. I hope you all enjoyed today's 3-hour symposium, including roundtable discussions with 6 Asian doctors, in addition to a special speech provided by Dr. Kasai and 2 more keynote speeches by Dr. Kato and Dr. Matsumoto. Okay, now as a closing remark, I'd like to thank all the participants in today's IUHW symposium. Today, we were able to actively exchange our experience during the COVID-19 pandemic and discuss how to stand up with lessons from the pandemic in order to prepare for new infectious disease pandemics. As you know, the population in Asia accounts for approximately 50% of the whole world. Therefore, it is very important to prepare for new infectious disease pandemic in Asia. We very much look forward to continued scientific interactions with our Asian friends. Finally, I'd like to thank the AMED and the Japanese government to support our program. Thank you very much. Thank you.
Thank you.
Thank you. Bye-bye.
Thank you.
Thank you and bye-bye.
See
Bye
you.
bye. Thank you.
To stop.
Recording stopped.
you.